Then the case?
Yes. So hello from Nicosia, American Heart Institute. My name is Dr. Michalis Neophytou. I'm going to present you our live case today. So this 59-year-old male came to us about 6 weeks ago with an acute inferolateral wall MI. In the ECG, we saw ST elevations in 2, 3 AVF and ST depressions in V2 and 3. His cardiovascular risk profile, heavy smoker, hyperlipidemia, hypertension. The transradial echo that we perform in our ICU showed a severe hypokinesia of the lateral and posterior wall and an ejection fraction for about 40 to 45%. At admission time, his vital signs, the patient was stable. The medications that we gave before the angiogram, 180 milligram ticagrelor PO, 300 milligram aspirin, heparin, and agrastat IV bolus and effusion. For the coronary angiography, we used the right radial artery, which shows the 6F slender as sheets. And from the ECG, we suppose that the right coronary artery is occluded, so we have started with the left system, and we used a 3.5 Jenkins catheter, a diagnostic catheter, with the aim to take a guide for the right coronary artery. So you see the left system here. The proximal circumflex seems thrombotic occluded. The mid-LAD contains moderate to severe disease with about 60 to 70% stenosis. So we continue with a diagnostic catheter for the right system, and we see that the right coronary artery is proximally occluded. And if we see the previous picture, we see that in the left system, we see some collaterals going to the right coronary artery. So what's next? Is the RCA the culprit lesion? Shall we do the RCA? Is the circumflex? Shall we do the circumflex? Shall we do both? Or shall we do both, plus shall we investigate the significance of the LAD stenosis? If someone from the panel has a comment about what are we going to do next?
This is a great case, and it's one that we've all seen and not wanting to see 3 vessel disease. So this was done as a primary angioplasty.
That's a primary angioplasty, exactly. And
the tirofiban was given up front?
Excuse me?
No,
the agrastat was given beforehand, or was that given in the lab?
It was given before the procedure.
Okay, so perhaps I can pass you on to my panel to say how they would tackle this case.
Hi, it's Sachin Jadhav here from Nottingham.
Hi.
I think you're struggling really to understand what the culprit lesion is here, aren't you? You know, because it could be a non-dominant right with a big circumflex. I think option 4 for me is off the cards. I think in this case I'm just going to deal with the culprit. Looking at the angiogram, you sometimes get a clue as to which is the acute lesion, and as you say, there are collaterals to the right. I'm not sure if that helps you decide what the culprit is here, but I think pragmatically, I would probably. Pragmatically, I don't think you're probably going to understand what the culprit is until you start probing it with a wire. So I think, for me, I would probably choose a circumflex and let's see how it behaves with the wire, and if it goes through and it's soft thrombus, then you've made your decision.
Okay.
Okay. Any other comments, or shall we?
Hi, Savas. It's Evangelos. How are you?
Hi, Evangelos. How are you?
I'm fine.
Good.
I would do actually similar. The circumflex looked to be more like the culprit with the occlusion side, and I would probably just palpate the circumflex with a soft, just standard BMW wire. If it flies through, it's very soft, and it's probably the culprit. And then if the patient is hemodynamically stable and well in himself, I would then take him off the table and do the rest another stage if necessary, depending on
Thank you.
ischemia testing.
Thank you very much. Okay, we'll show you what we've done, Michali.
So exactly, we have proceed with a circumflex PCI. which shows as guide 6F CLS35, a guiding wire BMW, and the BMW crossed the lesion without difficulty, so we assume that we did the right thing. We used an aspirations catheter, an expert catheter, and in the second film you see the result after the aspiration. And then we have proceeded with stent implantation, which shows 3.0, a long 33 millimeter combo stent, and we have post-dilated with a 3.5 15 millimeter NC balloon. And in the second picture, you see the final result of the primary angioplasty.
Any comments on our choices? Anybody would have done any differently, or?
The result looks great. You've obviously opened the culprit artery. Can you tell us a bit about the choice of the combo stent?
We chose a combo stent for his safety profile, and because the patient, we were not so certain about his compliance, and that was the main reason that we chose a combo stent.
Do any of the rest of the panel have any experience with the combo stent?
I've put in a few combo stents, but not recently, and I think certainly when they came out, the dual antiplatelet duration was 6 months, so to me it didn't really seem to offer much of an advantage over
Can we play the video?
The forerunner of the genus, or in fact a bare metal stent really, so I've stopped using them.
Well, basically that's the idea of using the sirolimus eluded stent with combo with the antibodies that we think that the dual antiplatelet regime will be less than or not as prolonged as we usually do with the rest of the stents. Of course, this is an acute MI, then the year is the year for the situation, but in case you need to use it less than a year, maybe combo is a good idea. Of course, there's not that many data yet, but hopefully we see new data coming the next few years, and maybe this is the way to go.
Okay, so we did, as Evangelos suggested, we treated the culprit lesion. We got the patient off the table. He recovered well from the MI, and he went home. Mihaly, can you continue?
So the final results looks very nice, but we still have a problem with residual disease. We have chronic occluded RCA and a moderate to severe mid-LAD stenosis. Here you see a picture of before the angioplasty, where we see the mid-LAD stenosis a little better and the collaterals to the right. And this is the patient's echocardiogram 2 weeks, 1 month after the angioplasty. We still see that his injection fraction is about 40 to 45%. So what do we do now? We have the option to leave everything like this and go conservative with medical therapy. We can investigate the significance of the LAD stenosis with possible PCI or possible elective cabbage. We can do direct the LAD, or we can do the above plus minus RCA-CTO PCI. That's our therapeutic options.
Any comments from the panel about what they would have chosen in this situation?
Yeah, I'd like, Stefan from Austria again.
Hi.
I'd like to add a sixth point, which would be non-invasive stress testing, like stress MR or stress echo.
Sure.
Find out what is needed.
Sure. Okay.
If you're doing a stress MR, I think that would also give you useful information about viability across the inferior wall, because with that CTO of the right, I think before you embark on revascularization, and if you've got a bit of time, you may as well confirm viability before you start thinking about complex PCI or even bypass surgery.
Sure.
It's Evangelos. I mean, I feel if the echo shows that the inferior wall is moving, if it was only hypokinetic, then I would assume it's probably viable and you could see it backfilling from the LED. I probably would go on and do number 3, probably do an FFR on the LED, and because it looks significant. and then treat it, and if the patient is asymptomatic afterwards, I think that's all that is needed.
The difficulty of FFRing the LAD in this situation is that it's also collateralizing the RCA, and the FFR is going to be a reflection of the fact that the LAD subtends the whole of the RCA territory as well. So you're only going to, the only way you're actually going to get an accurate FFR of the LAD is to open up the right, get normal perfusion pressures across the right coronary artery, and then FFR it.
Okay, well, we discussed in length with the patient about the options. The patient was adamant against CABG, so that option goes out of the window. We felt that, I mean, as a personal FFR enthusiast, I believe that the LAD FFR does reflect the collaterals to the right coronary artery, but you know, treating the LAD would also help the collaterals if that's shown to be significant. So we decided to do an FFR today. In fact, we use the IFR, the non-adenosine pressure measurement, which I'm sure a lot of you are aware of, or if you're not, we can show a couple of slides about that. Our strategy is to do an IFR, and then depending on the result, we either proceed to an FFR or to an angioplasty or not, depending on the result. Does any of you use IFR in their lab? Are they familiar? Are you familiar with this?
We've just had IFR put into our lab this week, so I haven't got any experience of it yet. I don't know about how many of the audience are using IFR rather than FFR now. So, Savas, it's probably less than a quarter of the audience using IFR rather than FFR at the moment. Okay. We just also maybe ask the audience who would go along with Savas's option 2, and who would go for an ischemia test, a non-invasive ischemia test, or wait for symptoms. Okay, the conservative British population are doing an ischemia test or waiting for symptoms, but
okay.
I think there's probably half the population are also with you on invasive measurement of ischemia. So
okay.
We'll wait and see what you find.
All right. We'll show a couple of slides on the IFR, and then we get on with it. Mihaly?
So, in simple words, IFR is FFR without adenosine. Here we have the definition: instantaneous pressure ratio across the stenosis during a wave-free period when the resistance is naturally constant and minimized in the cardiac circle. When we use 0.89 cut point from the IFR, for the IFR, that matches to an FFR cut point from 0.8. This has a specificity from 86%, but only a sensitivity from 73%. If we use the hybrid IFR-FFR approach, and this is what we use in our cath lab, we take a cut point of 0.85 and a cut point of 0.94 for the IFR, and everything under or equal to 0.85, there are significant lesions, they need to be treated, and everything equal or above 0.94, there are not significant stenosis. If we have a measure in this gray zone, then we have to perform an FFR. With this approach, we have a specificity on 90%, 92%, and a sensitivity for 96%. And this approach is also approved from the FDA with in order to use an FFR measure when we have an IFR measure in this gray zone. So, thank you very much.
Okay, so let me show you, Steve, can we show the pictures from today? Can we show you the angiogram from today? So the stent is nice and patent, and this is the LAD image, which to me looks perhaps a little bit better than it did in the peri.
Thomas, can we clarify? You're going to do the LAD dependent on this, and you're going to leave the right coronary artery for symptoms?
We're going to leave that for symptoms, plus or minus ischemia viability testing, depending on the clinical situation.
Sure. Again, this is a great case because it's the sort of thing that we're all faced with on a weekly basis, and you can argue it any of your options 1 to 5, depending a bit how you feel about the patient, really.
So this is the LAD today. So we're just going to start doing an IFR, and then we'll see how we get on.
I just have one question for the panel. Whether would somebody consider the CTO revascularizing the RCA, antegrade, retrograde, the presence of the LAD disease in the retrograde approach? Would that be a concern? And the chances of getting an antegrade approach successfully revascularize the RCA doesn't seem to be a straightforward antegrade case. Would somebody comment on that? Whether the LAD then has to be treated if we ought to do a retrograde approach?
Heparin.
It's, well, I can just about remember the shot from the right, but I think what would be really useful to have is a dual injection so you can see the right coronary artery properly. But
3.
I think if I was going to use a retrograde approach, I would do what you're doing and fix the LAD first of all. I think that stabilizes the collaterals and hopefully patients are here a bit more stable.
That's a good point. That's what I think we need to really sort out the LAD, whether it should be treated, and if the patient is asymptomatic, consider medical therapy until he becomes symptomatic, and then once he becomes symptomatic, then we probably ought to fix both, I think. Unless the LAD is significant at this point, and we would go on and fix it today, I guess.
Okay, can we normalize?
I would like to stress a point again. If I was planning to go retrogradely to the RCA, I would maybe try to prevent stenting the LAD first and do this in one session later so that I can use all the septal branches for access to the RCA.
Okay,
Good
so
point.
I think. Sorry, yes, carry on.
Yeah.
Carry on.
I think you have to be very careful in your interpretation of FFR in this setting, because frequently it's the case that if you open the right coronary artery, then your FFR of the LAD will be completely different, because the amount of territory that you're actually supplying before opening the CTO is much larger. Therefore, your FFR is more likely to be less than 0.8. And frequently the case when you measure the FFR after you've opened the CTO, it will not be significant in terms of ischemia. So a non-invasive assessment is a much more sort of accurate way of assessing this.
The question is it if you're not intending to open the right coronary artery, then is your current FFR down the LAD not still valid? Because you're looking at the situation that you're supplying at the moment.
Yeah, you don't think it's just do a non-invasive test and then you'll know all the information and you won't have to be invasive?
Yeah, I take your point. I mean, personally, I think that if we decided not to treat the right by CABG, then by treating the LAD, having a significant FFR would also help the right, because that, I agree with you, reflects ischemia in the right coronary as well.
And if you're being the devil's advocate, if this person went for a bypass, do you think that the surgeon's only going to put a lima on the LAD? The reason why we probably don't do as well against bypass surgery is because we don't fully revascularize patients.
I totally agree. I think with the data that we have from PRAMI and Culprit, I think we know that these patients do better with full revascularization, and I fully take on board that CTOs, etc., weren't randomized in PRAMI, etc. And I think we really ought to be aiming for complete revascularization. Now, 5 years ago, it would have been my practice to try to open the CTO of the right, and if it wasn't successful, send them for surgery. But these days, where we've all got a lot more experience in opening CTOs, I think I can assume that it is openable, and I would revascularize both LED and right coronary artery.
Did we see the right artery already this time?
We haven't seen it, no, not this time.
I'd like to see it because it might be quite different from the acute situation.
We can do at the end if we have time. Something wrong with the pressure.
We don't have a tosina. Εντάξει.
Okay. If we look at the IFR screen, there is quite a gradient at rest. So we're just going to measure an IFR. Εντάξει εκεί. Έχεις καλά. Ζαλίστηκες λίγο. Πού τα φάρμακα. We have given some nitro about 5 minutes ago, so
we have a low blood pressure. And
okay, do an IFR. Okay, can you see the IFR screen?
Yep, we can see that.
Can we do a pullback to verify that it's not drifting?
Yeah.
Let's wait for the blood pressure.
Helen, sorry, I'm just gonna, but I find it interesting that we are gonna do the LAD without any symptoms or anything, and yet we're basing the revascularization of the right on symptoms. If this right was 99%, you probably would have gone ahead and done it. And reading the IFR or FFR in here is going to be very difficult to interpret. It is going to be positive no matter what. And we have done many cases where you open the CTO and you find the IFR or the FFR is completely changed. And also I share the point that if you put a stent across any septal, you're going to struggle to use it and you might have issues with contraption of the corsair or the microcatheter. And I'm just trying to kind of understand why you're not doing the right.
I think you're right, and I think this is why I say that the decisions, you can apply each bit of evidence to your patient depending how you want to apply it, but in this case the patient said that they don't want surgery. So do you then at that point say, well, we'll do the best all we can do and leave the CTO?
Well, that's the good question. It's like, there's a consolation, as my colleagues
say. Low blood pressure, basically that's why.
Okay, there was some drift, so we have re-normalized and we're crossing again.
But I guess the alternative approach, if you were being a bit more purist about it, then would be to do our non-invasive ischemia test and then attempt the right coronary CTO if there's inferior wall ischemia. But as we all know, it also depends on the age of the patient, the condition of the patient, their preference about surgery, and all these things come into it, and then you can apply whichever trial you want to.
But the thing is, we considered bypass for this person, so which means, as the question has been asked, if the surgeon goes in, they're not going to leave the right. And in fact, actually, I wouldn't be sending this person for surgery because the patency of any vein graft on occluded right is very low at 1 year. And it's a mid LAD lesion, but that's a completely different argument.
But you could then put them into a different category and say, when you've treated the LAD and they've got CCS class 1 angina, then can you fit them into the courage category? Because then it's perfectly reasonable to treat their stable angina with some tablets.
Problem is then when he's still got his blocked artery and he blocks his LAD stent, and then he's right in the proverbial canal without a paddle.
I think this patient's slightly different from the courage patient in that they've had a recent STEMI, haven't they? And I think there's good evidence that complete revascularization post-STEMI is a good
How long
do they stay in that category before they change into the other one
well,
without any events?
Well, yeah, that's
Now we have better tracing, better blood pressure wise.
To FFR.
Mm-hmm.
Do it again. Okay, the IFR seems to be very near the gray zone, so I think we should do an FFR. Does anybody have any comments or?
As someone that's never used IFR or this hybrid approach, I would just be interested to know, in how many cases do you not need to do an FFR? I.e., does this actually save you from
Actually,
just the FFR?
The Advice 2 study with the IFR, there was about a 60% adenosine-free rate if you do the hybrid approach. So 2 out of 3 cases you can do without adenosine. Anyway, in this case, we are going to use adenosine, which we give through a vein in the antecubital fossa with an intravenous infusion. We ready? Start. So we are giving the adenosine now. Aquí βάλαμε το σύρμα και μετρούμε να δώσουμε ένα φάρμακο το οποίο να προκαλέσει λίγο βάρος στο στήθος. Εντάξει, να το πάρεις για κανένα 2 λεπτά και να το σταματήσουμε. Εντάξει.
So while we're waiting for that, Savas, your primary PCI strategy of giving tirofiban up front, is that who decides on that? Is that the paramedics who bring the patient in, or is that a strategy across the whole of your service?
Well, the patient come here from various sources. It depends on the referring physician, basically. I mean, this particular patient came from another hospital, so they had already started the tirofiban. So when I received the patient was already on tirofiban. If the patient presents here, we quite often give tecaclerol, heparin and aspirin without any agrastat or tirofiban. I guess it depends on the thrombus load. And I think in this case, there was quite a lot of thrombus present in the circumflex.
It is not uncommon in Cyprus, actually, when somebody is having an acute MI being transferred for a primary angioplasty to be given 2B3A inhibitors. And the only 2B3A inhibitor we have in Cyprus is tirofiban. So there have been some data showing that facilitated, if you will, using 2B3A inhibitors in an acute MI prior to entering the cath lab. There is some controversy, I know, but depending on the situation, it might be helpful. Especially in the transradial era, that bleeding is not an issue from the groin in such cases.
Okay, so the FFR shows clearly a significant lesion, and I do take into account your comments about the right and the interpretation of this. But our plan was to treat the LAD should the FFR or IFR was positive. Any other comments?
I have comments from the audience. I think there's still some concern about it impairing your ability to do a retrograde CTO approach to the right coronary artery, either electively or if the patient complains of symptoms.
Okay.
I would just like to see the RCA again.
Would somebody try to do the right first and then consider the LAD?
Let us just see the right again before we decide.
Okay, sorry about that. I guess we could take a look at the right. Could we have a right coronary, please? Catheter? It's okay.
Okay, we look at the right again.
JR4, please.
You can put on the screen.
JR4, yes.
I like this program.
That's okay, we'll fix it on our own. Okay. Come on.
So can I just ask those people in the audience who want to preserve the ability to do the right coronary artery CTO, if you like the look of it now, are you going to go straight on and do that without an ischemia viability test, or are you happy with the echo that shows the inferior wall moves?
You mean do the right now?
I think there
instead
are
of the LAD
people at the front suggesting that.
Mm-hmm.
It's a very difficult condition where you decide whether to go ahead or not. If there's movability, or if the left ventricle is moving, and usually in the presence of class 3 collaterals, there's about 50 to 60% viability in the myocardium anyway. But of course, if it's too complex, and I think it's probably a viability test or an ischemia test might be.
Yeah, that's a good idea. We are getting our cardiac MRI within the next few months or so. So maybe we could wait for that.
Pragmatically, you say if the inferior wall is moving on echo and you've got CTO, by definition, there must be ischemia. And I think that's justification in itself to open the right coronary artery.
We can sell you an MRI scanner if you want, guys. It has been vomited on recently and stopped working.
This is Alan Harcombe from Nottingham. I just comment, as was mentioned earlier, as Sachin mentioned, about full revascularization. And the decision here is often made based on how easy things are. So the LAD looks easy, so let's do that. The right, though, it doesn't look easy, so let's do lots of tests. Basically, for a CTO operator, this is a combined procedure where you go in. If the collateral is involved with the stent, don't stent it yet, use the collateral, do the CTO, and then stent the LAD on the way out. If you get into trouble, stent it while you're in the middle. The LAD is a 3-minute portion of an RCA CTO procedure and isn't really an issue. If the right coronary had a 90% lesion, you'd have already done it. The fact that it's a CTO makes people switch to a more dangerous course of action because, and I think I have to compliment our colleagues in Cyprus, a great case, really well chosen, and really useful to illustrate these issues. But if you put a stent in the proximal LAD in a man in whom you doubt his compliance, you may well kill him if you don't open the right coronary artery. So I think the strategy here should be to do the whole thing. It looks perfectly amenable to treatment, and it should be a combined procedure in my view.
Okay. Have you seen the right coronary injection?
Okay, this is the right.
I think that should be amenable to antegrade approach. There's a nice.
I agree.
Short occlusion, and should have a high success even antegradely. Which probably means you probably repeat the FFR of the LAD at the end and see what it is at the end.
You could try that, I guess.
Any other comments?
Yeah, the lesion is short. The occlusion seems to be short. There is some contrast going probably through. And
any comments on the choice of guides and all that for the right, for the antegrade approach?
Well, that depends what are you planning to do. If you are planning to try antegrade only,
yeah, I'm talking about antegrade.
And stop if you do not succeed and go for a second try, then you can just stick with a small catheter. But if you plan to do this in one session, you have to take the bigger catheter right away.
The question we didn't ask at the beginning, and I don't know, I'm sure other people have seen this, quite often when you have somebody with MI, and we've had a few cases like this, you find one artery that's occluded, another occluded. You think it's chronic occlusion, and you palpate it, you find the wire was through, and it is a thrombotic occlusion, which makes you wonder whether this has been the case or not, despite the presence of collaterals. But we've had quite a few cases in that respect. Two arteries are occluded at the same time.
We're in.
So, Savas, we're going to run out of time here because of constraints on the room availability at our end. So,
okay.
What are your thoughts about what you're going to do?
Well, we are going to take your advice and try and open the right.
I think that's a really good plan, isn't it?
Yeah, I mean,
it doesn't look that challenging, but you can never tell. You know, it might be impossible to integrate.
I mean, I'm sorry we ran out of time, but I thought the case would create an interesting discussion, which it has, I think.
I mean, I think it's a challenging kind of dilemma that, you know, the first time this patient presented, it was very difficult to know what to do there, and now you're faced with the problem of where to go with the disease that you've got, you know, a significant lesion in the LAD and a CTO of the right. So probably most people here would vote for trying to do the right and then fixing the LAD, or repeat the FFR at the end of that. But, I mean, we'd love to stay and watch, but we're going to have to go because the room's going to close up at this end. So what I'm going to ask you to do, Savas, is when you finish to send me an email and send the pictures over, and we'll send them out to all the delegates so they can see what was done.
Sure, I will do that.
Okay, so thanks for joining us. Sorry we can't stay longer, but we're probably going to have to end there. Okay, cheers, guys.
Thank you all.
Thank you very much.
So it would be really interesting to stay and see how they get on there, but I just think we've got to end, really. So I'll just say a couple of things. So thanks to all the sponsors. Thanks to everybody for coming along and participating. And hopefully we'll see you at the big international one next year. Cheers.
Okay, can we have a 6
French? We have a filter XT.
I'm going to try the right, yeah.
Φέρεστα Gaia. Καλύτερο το right όμως. Could we play the right εδώ?
Ξανακάμε το LED και κάνει.
Όχι, αφού θέλουν να τους μεταφέρουμε.
Αλλά δεν ξέρω αν είναι viable το right.
No. Oh, okay.
Okay, we're carrying on.
Μας βάλει τα τούτο. Should we use an AR1?
Let's use a JR4 to start with.
I'm surprised it's 73, huh?
Το δεν καταλάβουν είναι ότι you treat the right as well. You treat the FFR, you treat the right. Σε καλά, Άκη? Εντάξει. Λοιπόν, προχωρούμε. Είσαι offline τώρα, δεν σε βλέπει κανένας, μόνο εμείς. Εντάξει, τελειώσαμε τη συζήτηση και προχωρούμε να κάνουμε αυτό που... Και το χέρι. Εντάξει, άλλαξα καθετήρα γι' αυτό. We do an ACT.
Η δεξιά του, Μπίλια, put the right corner here. Ναι, είναι. Συνέχισε τη δεξιά μας.
Έλα μπει.
ACT. Filter XT.
Μπορούσαμε να πούμε ότι να κάνουμε το LED και το right it looks you can do retrogradely και τελειώνει η ιστορία.
Actually, we do complete revascularization.
Who's going to pay for it? Who's going to pay it? Bloody stupid. Let's have the wire. No, XT, FC, FC.
Give us filter XT. Filter. Κύπρο. Έχει πίσω. Πίσω.
FC, with FC Κύπρο. FC.
Πίσω έχει σύρματα.
Έδειξαν το βίντεο στην αρχή.
Δεν ξέρω, δεν μπορεί να μην τους βλέπεις.
Μιχάλη, έδειξαν το βίντεο στην αρχή, εκείνο που τους είπα, της κλινικής.
We have one zero balloon.
Το είδα εσύ. Μαλάκες.
Collider. That's it. Coming, getting out of the vessel now. Does it come back?
Και πρέπει να βγάλεις τη μάσκα.
Some atropine, please.
Ναι.
Τάκης, εντάξει. Point six. Point six. I think there's a an RV. We are in pass through. I think if you need to come back, there is a small RV margin of branch. Oops. an RV margin of range. I think you have to really continue looks an RV margin of branch where we are now. So come back into the groove. And then there. That's it. Who could have the balloon? It's not worth it. Let's try one more. F2 o lo Isus. ¿Qué proporción era? To navázte to mikrofon na doval.